Our next speaker is from the United States of America. Dr. Deborah Riczo is a specialist physical therapist, educator, and author in pelvic girdle, sacroiliac dysfunction, pregnancy, postpartum issues, women's health, and breast cancer. She obtained her bachelor's in physical therapy and master's in sports management from Cleveland State University and a doctorate in physical therapy from Marymount University. She is a licensed physical therapist in the state of Ohio and the founder of Riczo Health Education. I would like to invite Dr. Deborah Riczo.
Thank you so much for that introduction and for inviting me to this wonderful webinar. I really enjoyed Madam Harding's lecture, and it's always so stimulating to be updated in current practice for areas of the body that no matter what area of practice we are in, we are going to see these conditions. We're going to see scoliosis, even if we're a knee expert or a shoulder expert. So this is just a wonderful sharing of ideas. And I think hopefully you will feel the same after I get done with my lecture, because all of our patients have abdominals and pelvic floors. So, so with that being said, I'm going to share my screen. Okay. So first, I'd like to start with a disclosure statement that I am an author of 2 books, Sacroiliac Pain, Back and Pelvic Girdle Pain in Pregnancy and Postpartum. And I'm also an instructor, and I teach on the platforms of Motivations, Physiopedia, and the American Physical Therapy Association Pelvic Health Academy. And I do receive royalties from this work. So first, the objectives for the next hour is to discuss what is Diastasis Recti Abdominis. And I'm going to be abbreviating it as DRA just because it's a mouthful. And that's what the literature uses, is DRA. And look at DRA and what are the clinical signs and how to test for it. Understand the beginning exercises. And then we're going to move on to the pelvic floor and talk about what pelvic floor dysfunction actually is, and discuss the symptoms and disorders of that dysfunction, and understand when to refer to a trained physiotherapist. The agenda is going to mimic the objectives. So for the first half, we're going to talk about the definition, the muscles of DRA that are involved, the clinical presentation, testing, treatment, and then referring to specialists. And then it's going to mimic the same thing with the pelvic floor dysfunction. So if we look at, this is a typical picture you will find if you look up DRA, and that it is a widening of the area between the rectus abdominis. So we have, and this tissue, I'm sure you are all aware, is called the linea alba. And this is a widening of these tissues. The actual widening can occur at different points along the linea alba. So this is probably the most typical, but you can see it below the umbilicus and above, and then just a general widening. Now, we all have a DRA. We all have a diastasis. It's how our bodies were made. We have the linea alba. So some people's linea alba is a little bit further apart than other people, just like we see variations all the time. So that's kind of an important concept, because especially women who may be going through childbearing years will be very concerned because they can feel it, but it's normal to have at least what we call a 1 finger separation. When we get larger than a 2 finger separation, that is where we're going to be considering it actually going towards pathological. So right up here, you can see where the fingers are coming into the area, and it'll be clearer in the next few slides. But we are looking at assessing the DRA as a resting tension. So when a person is just laying on the ground, laying flat, and then we're using our fingers in this method, and we can palpate all the way up and down, and we should be able to feel the mounds between the rectus. And then also with muscle tension, and that is usually generated with a head lift, to see what the separation feels like. So those are the 2 ways you would be assessing it. Now, what is considered pathological is a separation that's greater than 2 centimeters. And like I said, usually we use, in the clinic, we use 2 fingers, but that is, obviously not tester reliability. And there are other methods that are used in research to actually measure the diastasis, being calipers, a flexible tape. CAT scan is the golden the golden way of doing the assessment. So mild is 2.5 to 3.4, and then severe is considered 5 to 20 centimeters. So you can actually have a diastasis that is very large, and it is very disfiguring, and it is a problem. So that is why we need to be able to. So what is actually happening on a muscular level is that our abdominals, our obliques, the externus and the internus and the transversus, are by their aponeurosis are pulling on the recti. And then that is the aponeurosis actually forms the linea alba. So when the transversus is contracting, we are getting tension here on the linea alba. And when it's not, when it's at rest, there is no tension. So you'll be able to feel that in the clinic, the difference for that. And we're going to come back to this slide, but this is just basically the anatomy. This is a cross-section view. So clinically, this is what it can look like. This is considered the doming effect, and you'll see that in the literature. And this is what the belly can look like. Now, you won't really know what the width is of the diastasis until you palpate for it, as we just discussed. So 66% of women immediately after having a baby will have a DRA, and that number might even actually be higher. 33% of those do not resolve on their own. And these, of course, are just estimates. So it is important, if you're seeing really any woman that has given birth, to check their abdominals. And actually, I believe that you should be, when you're doing your screening assessment, it's very easy to check abdominals on your patients in general if you have any inkling that there's something going on. So it's not really, this does not really just occur in women. This can be found in newborns. You can see that the diastasis in this newborn. You can find this in men. I had a lymphedema patient that I was treating, and bilateral leg lymphedema patient I was treating, and he had quite a significant rectus diastasis. So it does definitely occur in men. In standing, this is what the posture can look like with a more severe DRA. And then, of course, this is a normal looking abdomen. And this is the a surgical repair of the DRA. So you can see that they're going in by layer. So surgery for the extreme cases is for sure, a treatment. This for sure, it would be indicated if the linea alba is actually not just stretched, but that there is a complete separation so that you would be able to get your fingers in past the linea alba. But again, whether you go to surgery or not is an individual case. There aren't really any guidelines that are in place that will help you with that decision. And a lot, of course, would have to do with the patient and their goals and their beliefs. So when you generally are not going to be getting a referral for DRA, although you may, but the likelihood is that you are going to find it on patients that you are seeing. And the low back pain patients, the pelvic floor dysfunction patients, people that have hip and groin pain, and many others, like I just gave you that example. So it's very important to screen the abdominal wall integrity in all of our patients, because as we know, our core and how strong our core is very important to how effective our treatments are going to be. This is a typical test position, a screening position. So this is with the woman bringing her head up, and the therapist is putting their fingers in by the linea alba above the umbilicus in a crosswise plane. So, and then you'd be palpating all the way up. And this is going to be a video that is linked to my prenatal postpartum book that patients can see, but I thought it might be helpful to actually listen to this.
This is a Diastasis Recti Abdominis check and instructions on how to activate your core. Lying on your back with your knees bent, place your fingers above your belly button so your fingers are pointing toward your feet. Lift your head off the ground and feel for a separation of your abdominals. If you see a mounding or coning of these muscles, you know you have a Diastasis Recti Abdominis or DRA. And now you can put your head down. When you activate your pelvic floor and transversus abdominis muscle, as instructed in the book, it will put tension on the valley area or the linea alba, and you will feel tension under your fingertips. A beginning exercise to work on the DRA is in this position. You're going to inhale and then slowly exhale through pursed lips, lift up the pelvic floor and draw in the belly. Feel for the valley or the linea alba area to become firm. This is how you know you are activating the deep abdominals or the transversus abdominis. Now inhale, and while slowly exhaling through pursed lips, lift your head up off the ground and maintain that tensioning firmness of the linea alba. The goal is to engage your core in this manner during all the progressions of your core work in this book, so it becomes automatic. This is the same core exercise that is done, even if you do not have a DRA.
So
this is a Diastasis Recti.
So I wanted to put this slide up again because to kind of just reiterate what was going on there. So when she first picked her head up and did not engage the transversus, then there would be more laxity in the area of the linea alba because the TA was not, or the transversus abdominis was not pulling laterally on the rectus and creating this tension through here, as in this bottom picture. So this is new thinking. This is what I was talking about when at the beginning of the presentation, was that this is new thinking, that we don't have to be as concerned with closing the IRD, or the interrecti diastasis, that separation, the IRD. It's more important that we are having tension translated through the linea alba. And this has been in the literature in the last, I would say, 5 to 7 years. And it's becoming more mainstream. But I used to teach the Elizabeth Noble method of putting your hands across your belly, doing a head lift, and pulling the rectus abdominis together. And that was what was accepted at that time. So now the thinking is that we're just trying to get that tension in the linea alba, because if we have that tension throughout the abdominal canister, that will help, that will be what the body needs for functioning. So the interventions are very poorly researched. The studies that are out there are not necessarily very good studies. And we already talked about treatment as far as surgical versus conservative, but we will, the exercise, there is a systematic review done in 2014 about how exercise can reduce the DRA by 35%. But again, when they're doing comparative, the studies were of poor quality. So some intervention key points are, if we start on this part of the slurp out exercise, that we want to engage the pelvic floor, the transversus abdominis, and the diaphragm in a good with a good breathing strategy when we're doing our core strengthening, our glutes, and our scapular strengthening, when we're really addressing the whole core. So that will actually help, because we know we have to strengthen the rectus and the obliques. It's not like we don't have to strengthen them, but if we do it in a fashion that we're not engaging the TA, it can still be sleeping. It won't be active, and will just be not addressing the full problem. So the techniques you want to do is engaging the inner core muscles, which are the diaphragm, the pelvic floor, the multifidi, the TA, and so that they're all working together while you're doing your strengthening. So that would be the number one thing. Now, when you're doing your exercises, you want to be monitoring for any doming. So if you see doming while you're actually doing your exercises, then you know that either one, the exercise is too stressful and you need to pull it back a little bit, or the person is breath holding or not breathing in a good pattern, their breath strategy. So basically, when you are initiating movement, you want to be exhaling as you move, and then inhaling. And we're going to go over that. I have another slide coming up, but the breathing strategy is going to be helpful, as well as monitoring the progression of the exercises, which is something that we always do. So we're experts in exercise progression. And then we want to look at their gut health. It's very important, because if we have a very lax abdominal area and we have a lot of bloating or constipation or scar tissue, then that actually compounds the problem and the dynamics of what is going on there. So we need to address those things so that our rehab will be more effective. And this takes the form, of course, patient education and possible referral to possibly a GI person if they're having other types of issues that are beyond your wheelhouse. And then the scar tissue can be something very effective for you to work on. Someone that has had multiple abdominal surgeries, the scar tissue may be a big player in the dynamics of what's going on. And then when we're looking at our functional tasks, that is going to be all part of this big circle because as we know, their body mechanics, their ergonomics can be perpetuating bad patterns. So, and then again, that's of course right in our wheelhouse. And so just monitoring how they're moving, patient education, and then while you're doing that, making sure they're not having any doming, they're using the right breathing strategies. So these are very key intervention points, key points of intervention for DRA. And then the final comment would be on a compression garment. If you are having a DRA, especially within the first 6 to 8 weeks postpartum, there is definitely a school of thought, because we don't have actual research to back this up, but there's a school of thought that says that the compression garment will be beneficial. Because if you, and I agree with this, because if you think about having that one lady that was standing with her, belly literally hanging out, and the muscles are just so weak. And if you think about everything that has gone on during pregnancy and that last trimester and the labor, et cetera, having a exterior support to help those abdominals kind of come in and not always be overstretched every single time this woman is moving and caring for her infant, then that would be probably very helpful in the resting of the muscle as well as preventing it from being overstretched. And if it can help her move better, then the moving in general will help with the strengthening process. And of course, that would be hopefully in line with you giving them beginning exercises, activating the inner core. So that was my section on the DRA. And then referring to a specialist would be when you are, like, if you are assessing that this person has, of course, it's going to be on a case-by-case basis, but if you're assessing that this person has other issues, they have a DRA and they have maybe fecal incontinence or urinary incontinence, or other gynecological issues. And there is a strong link between finding DRA in urogynecological disorders. And there is research that does show that link. So when you're getting with multiple issues like that, that would be a great time to think maybe I should refer out unless you feel that that's within your wheelhouse. And then of course, excuse me. And then of course it would depend on if that was even possible in your area of practice. If you had, excuse me. If you had practitioners available in pelvic health. So it'd be a pelvic health physiotherapist. Okay, so we're going to talk about pelvic floor dysfunction. And I just kind of want you to think, I know we're not doing an interchange of talking because we have such a nice size group of people here, but just kind of think to yourself, what is pelvic floor dysfunction? What do you think it is? Maybe if you have a piece of paper, just kind of jot down. And I'm going to take another sip of water. So go ahead and jot down what you think pelvic floor dysfunction is. Okay, so if you Google what is pelvic floor dysfunction, you're going to find that you're going to find things that talk about the inability to contract and relax the pelvic floor so that you have problems with your bodily functions of urinating and bowel movements. Painful sex may be in there. So it has to do with those issues. That is what you're going to find. But if we really want to take a look at what pelvic floor dysfunction actually is, I think it's really helpful to look at what the pelvic floor does. What are the functions of the pelvic floor? So the pelvic floor, as we all know, is the sphincter. So that's with controlling our urine and our bowels. So we have that sphincter, and then of course the vagina also. It provides support to the pelvis, to the pelvic girdle, by the way the muscles are attached on the inside. And we're going to go into the muscles in a few slides. So it gives support. So anything that, if that muscles aren't working right, we can have problems with how the pelvis actually is supported. And what that would look like, what that would spill out like, would be a prolapsing of the organs, because there's the support of the muscles is not there. And so what it supports is the bladder, the vagina, and the rectum. Stability would be the stability of the pelvic girdle regarding the dynamics between the joints. So the symphysis pubis, the sacroiliac joint, the hip joints, all that stability. Sexuality, I think we all know that that's pretty clear. And then as a vascular pump, which you may not necessarily have thought about and put into the list, but by nature of the dynamic motions that occur automatically and autonomically contribute to the vascular pump. And so if we're going to look into that concept a little further, we know that when we inhale, the diaphragm descends and puts pressure, it descends, everything descends, and the pelvic floor relaxes. So this is a neurological, an automatic thing that we don't have any ability, we don't control. This is just normal functioning. So and then at the same time, when we exhale, everything comes back up. The diaphragm comes back up. It's a passive coming back up, where when we inhale, there's a lot of muscles contributing to that inhalation. But the exhalation is passive, everything rises up and the pelvic floor comes back. So that is what we call the pistoning action of the abdominal canister. So it's this up and down motion. And that is really critical to keep this model in mind when we're thinking about the dysfunctions and what is actually going on, and why the exercises that we're doing are addressing the dysfunctions. So what are the risk factors? Well, this slide can say more than I can even say, because during childbirth, the pelvic floor is a real trooper and undergoes a lot of stress. So that whole area of prior pregnancies is going to make it a higher risk factor. This is what the research is showing. Of course, if you've had any episiotomies or tears in the pelvic floor, the length of pushing, because you have more likelihood of having more tissue damage, forceps delivery, continence status, obesity, and age. So these are all risk factors for pelvic floor dysfunction. So other considerations for pelvic floor dysfunction is a history of urogynecological surgeries, especially if there has been any type of mesh or slings. The respiratory history of the person, if they have had a lot of excessive coughing, that just kind of pushes down on the pelvic floor. If they have asthma, if they have COPD, anything that is going to be affecting that pistoning action on a chronic basis is going to play some havoc on the pelvic floor dynamics. And then the GI issues, the gastrointestinal issues, which we talked about in relation to DRA, are also going to be very important. So if the person has irritable bowel syndrome or constipation, it's going to be a complicating factor. So let's take a look at the pelvic floor muscles. So I think that the easiest way for me, and I didn't really, I've been teaching in this area for quite a while, and the easiest way for me to get a grip on the pelvic floor, because there's a lot of muscles down there, if you've actually ever looked at the anatomy books, is to think of them in 3 layers. So we had the superficial layers, and I have my model here of the pelvis, and I think this is helpful. We have the superficial layer, which is the layer right here. And in this model, it comes off, which is kind of good. So this is the area where if someone has vulvodynia, this is considered the vulva. And these are the muscles that would be involved, the superficial layer. And this is beyond this course to actually identify all these muscles. I do that in other courses. And then this would be the second layer is the sphincter layer. Now we all know what the sphincters are, and you can see in this diagram here, the sphincters, I think, very well. So you can see this is the urine, the vaginal, and then the rectal sphincters. So these are the sphincters, the sphincter control feature, and that you can see very well. And then the inner layer is the bowl, which is right in through here on this model and right over here. And I'm going to just take this out. The other point before I move on is that, so this is the uterus, and then this is the vagina. So the vagina is actually a muscle, it's not really the outer portion. So if we're talking anatomy and anatomical terms, the vulva is the outer portion and the sphincter is the vagina. So I wanted to make that point. And then this would be the sphincter for the rectum. And we can see that this lies real close in proximity to the sacral area. And that's why this constipation is an issue if you have these tissues. And then, we have all the nerves right back there. Okay, so I'm going to take the bladder out. Now we have the bowl. So I've actually assisted teaching in a cadaver course, and my section was the pelvic floor. And it is truly incredible. It really is a bowl. And so the pelvic floor is complicated. I guess that is my point. It's got different layers, different functions, and the functions in this in the bowl area, which is considered the levator ani, is partially is the connections with the hip and the spine. And so this is where the stability factor comes in. And if we look, and I'm going to actually put this model down now, but if we look back at the PowerPoint, you can see that there's the piriformis muscle is in close proximity. And right here, you can see that the levator ani actually attaches to the obturator internus, which we know is a hip external rotator. It's one of the groupings of the small rotators of the hip, along with the piriformis and the gemelli brothers. So the interconnection with our hip and our hip rotation is significant. So the dysfunctions we have of the pelvic floor, it can be overactive. The disorders that are listed are what would be considered overactive, where the pelvic floor is lifted up. So we have levator ani syndrome, proctalgia, vulvodynia, dyspareunia, which is painful intercourse, coccydynia, our tailbone pain. And then we have the symptoms that go along with these disorders. So pain in these areas, incontinence, leaking, urge or stress incontinence, bowel, bladder problems, intercourse problems, tailbone pain. And then when we look at underactive, the disorders would be the prolapse, and that we had already talked about. And the symptoms are the heaviness and the bulging of the areas down by the pelvic area. The woman might actually feel like something is falling out, or she may physically see something or feel a protrusion. Again, you can have incontinence, stress urinary incontinence, and leaking. So just because someone is incontinent, we don't really know that that muscle is weak, which is a very huge point. And if you don't take anything away from this presentation at all, that this would be the thing to take, is that if someone has incontinence, it doesn't necessarily mean that the muscle is elongated and that they need to have Kegels, but it might. And that's where the pelvic floor internal evaluation will be able to really clarify whether or not what is going on, because they're both weak. The muscles are both weak. If they're hypertonic, they're weak. And if they're hypotonic, they're weak. So we can have incontinence with both. So there is good research that shows that pelvic floor muscle training is a very good treatment for when the pelvic floor is over elongated and it's weak, and that is the treatment of choice. So that is one of the interventions. The other thing is that because of all the interconnections between the pelvic floor and the hips and the trunk, and even the abdominals, because we know that there is a relationship between a DRA and urogynecological issues, that it's very prudent to do complete evaluation. And this is what pelvic health physical therapists do. They don't just evaluate the pelvic floor, they look at everything. And before you can make an assessment of exactly what's going on. And then, of course, referring to a pelvic floor physiotherapist, especially when you have a lot of comorbidities going on and it is outside of your wheelhouse. So in summary, we talked about what is, DRA, Diastasis Recti Abdominis, the symptoms, the interventions. We talked about the pelvic floor muscle dysfunctions and the symptoms and the relationship to core strengthening from the inside out. You definitely want to get those muscles working from the inside out, because if we are doing just regular strengthening and not paying attention to that, then we're doing a disservice because we're not addressing all of the muscles. Because when you have very weak inner core muscles, then and this is true for the hip, if you have very weak, glute max, then the small rotators will try to overcompensate and do the job. When the transversus and the inner core muscles are very weak, the pelvic floor muscles are very weak, then the global muscles kick in to try to compensate. So that is an important strategy to keep in mind, as well as the breathing, the use of diaphragmatic breathing, engaging the pelvic floor with the efforts when you are doing exercise and functional training. So let's see. So I just wanted to thank you for inviting me to talk about my passion and things that I love, because it doesn't seem like work. And I am available. I'm all over social media, which is what I've been doing during the pandemic, trying to take that next leap out there to reach actual consumers. Because my focus of my career, besides I practiced physical therapy at Metro Health Medical Center for over 30 years, actually in the clinic, as well as being adjunct faculty at our local university, and had been very involved in women's health, a member of the women's health section since in the 80s. So this has just been an area that I have focused on for my career. And so now I'm actually trying to get some of this information out to consumers. So if you are a social media person, I would appreciate you following me on one of my platforms And I didn't even put YouTube. I'm just starting YouTube also. So anyway, thank you. And I'm going to just open it up for questions. And these are my references. I guess I will stop the share. Okay. Okay, so I guess Dr. Deepali Handi, if you would like to ask your question.
Yeah. Good evening, ma'am. I'm Dr. Deepali Hande. I'm from India. I really liked your presentation, ma'am. And hello.
I can hear you. Go ahead.
Okay.
Thank you. Thank you very much.
Yes. So like you, even I'm very passionate about women's health physiotherapy. I want to ask you, ma'am, like in India, the awareness of diastasis recti and the pelvic floor dysfunction, it is very less, not only in gender population, also in obstetricians and gynecologists. So what is your experience in this?
Well, I think that was one of the risk factors is in the obstetric world for sure. And once a woman has had a baby, then if she hasn't gotten those muscles, you know, a lot of times she will have residual problems from her childbearing years that last forever. The research shows 7% of women really have significant problems for the rest of their lives after childbearing. So, and that can be, right, you know, all the various forms that we talked about. I'm not sure if I'm answering your question. So yes, I agree with that. And that has been my experience. You're welcome.
Hi, Deborah. I'm Tanya from Sri Lanka. I have a question for you. Thank you for your presentation first, but I have a question for you where you mentioned about compression garments for the use of diastasis of recti abdominis.
I'm sorry, you're kind of muffled, and I'm not quite hearing you correctly.
Can you hear me now?
Okay, I will try again. Go ahead.
Yeah, you did mention about compression garments for the use of DRA. I'm just wondering if there are any types of specific types of compression garments that you suggest, and if there is a period of use for such patients.
Yeah, so the question was about compression garments and if I have any recommendations and how long you would use them for. So we know that patients vary from person to person regarding the severity and whether it's helping and how they're progressing and all the other, you know, comorbidities that go with it. But in general, it's within that first 8 weeks postpartum that you would hopefully, of course, it depends on when you start your intervention too, right? Because if you haven't been working with them for the first 8 weeks and they have a significant DRA, then those are just guidelines. Those are the guidelines that they use. But you have to use your clinical judgment and whether you think that garment is doing an assistance. Now, you know, that would have to go hand in hand with actual treatment. I would recommend it to go. I mean, it doesn't mean that you need to see them 3 times a week, but it means that you put them on a home program that they understand how to activate their inner core and things like that, and make sure that they're not holding their breath when they're doing their functional lifting and when they're getting out of bed and things like that. When they're lifting their baby, that they're not holding their breath and that they're breathing with their functional activities. Activating that inner core muscle. As far as products, the one that I have used is called the Fit Splint. And I don't know if it's available in your area, but they have a prenatal and a postpartum version. And I do like that one, Fit Splint.
Thank you so much. But also, when given a day, during the day, is there a period of use for a given patients?
Well, you'd want to, the purpose of it is to help prevent the excessive stretching of the abdominals when the person's up. So you would want to use it during most of their activity when they're up, whenever that is.
Oh, okay. Thank you so much.
You're welcome.
Hello, madam. I'm a big physiotherapist from Vietnam. I have one question for you. So, as you say, the women post-spectrum have a high risk with pelvic floor muscle dysfunction. So, can we have some method for the women during pregnant for them to prevent pelvic floor muscle dysfunction?
Having them understand their anatomy as far as their inner core and with their breathing, having education as far as their toileting habits also, which sounds maybe a little bizarre, but you don't want them to be bearing down. So that whole constipation thing, because a lot of women tend to get constipated during pregnancy because it is all the intestines are like kind of smashed, smushed, and there's not that much room for our normal digestive process. Plus they might be on prenatal vitamins, which tend to be constipating. So addressing, their diet, that they're getting, enough fiber in their diet, enough water, because if they're not getting enough water, and that when they're having bowel movements or even urinating, that they're not pushing down and holding their breath downward on the pelvic floor. So I don't know if that answers your question, but keeping a healthy, toned pelvic girdle also. So, the gluteal strengthening, walking, just general fitness, so that they feel, because their bodies are going through a long, a progressive change throughout pregnancy. And then when they become postpartum, you want them to have, if they're very unfit before they have the baby, then it's going to be harder for them to bounce back. So just general fitness in general, so that because when you are walking, when you are doing things, your pelvic floor, and if you're breathing properly, should be having some dynamic movement anyway. And so teaching them the basic inner core exercise that we talked about. Now, you don't want to be having them doing any exercises laying on their back, because that's not a good position for during pregnancy. So you'd want them to do it in sitting. They can do it in side lying to activate that pelvic floor and know how to contract it, and then know how to relax it. And that will be helpful in childbearing, especially for vaginal birth, for labor, that they know how to relax the pelvic floor and that they're not tightening up with pain. So that would be a very important thing, as well as flexibility of the leg muscles for labor positions. Did that answer your question?
Yeah. Thank you so much. It's so helpful. Thank you so much for your answers.
You're welcome.
Yeah.
Any other questions?
Okay. As there are no other questions, thank you very much, madam, for your descriptive and informative lecture. Shall we move on to the next one now?
You're welcome, and I appreciated the invitation and the opportunity. Thank you.
Thank you very much, madam.
Pick up the brace and take the abdominal plate apart first. Take off the Y-shaped hook piece of the 4 straps. Place the brace on an even surface. Put the brace on back with the curve fitting with the lordosis and kyphosis. Pull the 2 straps around shoulder to the front side of the body and leave them hanging in the front. Pull the 2 straps firstly backward to the back and through the rings in the middle of the brace. Then pull the straps toward the front again. Recognize the abdominal plates with the rings facing outward and the oblique rings facing upward. Press the abdominal plate on stomach and hold it in place. Pull the shoulder straps continually through the oblique rings on the abdominal plates. Then use the Y-shaped hook to stick the straps with themselves. Pull the rest 2 straps around the waist through the other rings on abdominal plates and use the Y-shaped hook piece to stick the straps with themselves. If the straps are too long, use a scissor to cut them shorter. Adjust all the straps to proper tightness. Remember to adjust both sides of the straps at the same time. Try to walk, bend over, sit down with wearing the brace.